Good morning. Thank you for joining us. This is the Virginia Interfaith Center's Symposium, Bioethics and the Beloved Community, a symposium on protecting humanity, earning trust, and engaging with people of faith during and after the COVID pandemic. I'm Dora Muhammad, Congregation Engagement Director and Health Equity Program Manager. And I'm so very excited to have this be our culminating event for our initiative around COVID vaccine education and outreach. So we've did in the past few weeks, several articles, blogs, infographics, really to dispel the myths and the misinformation around COVID vaccination, but also pulling in and centering the bioethics movement. And so I did a personal blog on the story of Henrietta Lacks and sort of her case history and how that fueled informed consent as being a central part of the bioethics movement and healthcare delivery in this country. And so from that, we developed a larger kind of emphasis that really seeks to connect our faith-based advocacy with three grounding principles of bioethics, which are autonomy, justice, and beneficence. And the reason that's so central to us, for those of you who've been at all active with Virginia Interfaith Center, one of the things that we use for our basis of our coalition building is the phrase that all faiths believe in justice. So there was an automatic kind of affinity there as I looked into the principles of bioethics on a deeper level. And then with beneficence, it immediately struck with me because one of the two most oft-repeated attributes of God in Islam is the beneficent. So a Muslim does not open up anything that he does, begin anything that he does,
they have the shirt,
except in the name of Allah. And so that says, in the name of Allah, the beneficent, the merciful.
Okay.
Can you mute Dr. Lydell? Okay, yep, there you go. And so drawing those connections really was a focus, essential as sort of how the people of faith that we engage with in our advocacy can really ground their work with an understanding of bioethics as we continue to do our health equity advocacy. And so that's one of the purposes of this symposium. We want to present thought, information, and really a vision that really can help amplify some basics into sort of the lexicon of our health equity advocacy around healthcare delivery. So there's three key takeaways that we hope to achieve in today's symposium in the short term, but also in the long term. So first, we want to empower clergy and people of faith with a deeper understanding of their impact as health equity advocates. Second, we want to aid healthcare professionals to better engage communities of color. And third, we want to inform and inspire individuals in their healthcare decision-making process. So joining me today, you only see two, but hopefully there'll be three before the end of the program. I have three wonderful, just absolutely amazing medical researchers who have accepted my invitation to join me in trying to achieve these goals. So you'll hear first from today, you'll hear from Reverend Dr. Lydell Lettsome. He is a board certified surgeon, but who has shifted from becoming an attending surgeon to focus on the Vanguard Health Equity Project, which he co-founded. He's also a research professor at New York City's Union Theological Seminary. Also with me is Dr. Amira Roaz. She is just absolutely brilliant. She is one of the leading epidemiologists at George Mason University here in Virginia. And so she will be sharing with us, really just walking us through the research process. So very, very excited to have her. And then lastly, you don't see him, but we have Dr. Ruben Warren. That had some technical difficulties with the internet while he joined and dropped off. But he is the director of the bioethics, here he is, of the, right on time, of the Bioethics Center at Tuskegee University, which of course has been historically used sort of as a marker and as a litmus test, if you will, for medical mischief and sort of standards for bioethics. So there he is. We're so very happy to have him. So with that, we will hear from Dr. Lydell Lettsome first, who's going to lay the foundation for faith, for our understanding of bioethics, and sort of how do we connect with respect for one another.
Good morning, everyone. It's really a pleasure to be here. Sorry, be a little bit disconnected because as fate would have it, my fraternity is partnered with one of the local community centers. We're doing a pop-up vaccination site this morning. It was supposed to be last week, but it's got switched. So I'm wearing 2 or 3 hats in this hour. But I'm really glad to talk because we're living in interesting times. We're living in an era where we think we have a lot of information, but reality shows we have a lot of misinformation. And as persons of faith, and particularly for clergy and leaders of faith, and communities of color, clergy are also usually the community leaders. Regardless of how popular or how well attended your church may be on Sunday, it is still a sacred voice. It is still a trusted voice for the community. And I just hope as we go through this, that clergy and faith leaders will feel more empowered to speak truth to their communities about what's going on with this virus and what's going on with the vaccines. And moving from there, I would like to just sort of set up a foundation based on scripture, going out of 2 Kings chapter 5. And one of the more popular stories of where Naaman is plagued with leprosy, despite being a brilliant military leader in general. And he's captured an Israelite girl, and she sees him suffering from his leprosy and says to him, "Hey, there's a prophet in my homeland who I'm certain would heal you if you would go see him." And the interesting thing about Naaman is kind of just how we are right now as we are in May 2021. He was tired of being sick. He was tired of his life being compromised. Yes, he was having success, but he still couldn't live the life he wanted to live. He couldn't live the life he imagined, just frustrated, and he wanted to do big things and move on with his life. And he's told there's a way you can be free of this thing that's hindering your life. And he has enough faith to go and see this man in Israel, even though it's an area he's conquered, thinking, I'll take some treasure, take some gifts, and surely he will come and do his best effort to pay homage to me. When he gets there, Elisha the prophet just sends a messenger saying, tell him go bathe in the river Jordan 7 times and he'll be fine. He doesn't come see him. He doesn't entertain his entourage at all. He just sends Naaman away with a message of go and wash in the Jordan. Now, it was insulting because the Jordan was a muddy river, not the cleanest of places to go and bathe. And Naaman was ticked off by it. And he gets upset because the process for his deliverance doesn't make sense to him. He gets upset because he doesn't understand or have any familiarity with the process that could be his deliverance. And I really feel that's where we are in America. I just spent maybe 45 minutes ago talking to the sister of someone who's here today getting vaccinated, telling her, don't get vaccinated, it's bad. And I just said to her, well, give me a name. Just give me a name of who you know's had such a horrible experience. And she couldn't. I said, look, I don't want to hear any rumors. Give me a name. And at that point, she ripped my head off and said, how dare I insult her? And how dare I talk down to her? I said, ma'am, I'm just asking for a name. Rumors cannot be your truth. And to clergy, I would empower you and encourage you to access the health physicians in your circles, access the public health workers in your circles, use their data, use their reality to help you build your own reality. Because we kind of see that play out in Naaman's story. He's about to leave, and one of his entourage says to him, why are you leaving? Think of the choice you're making here. You go and bathe in the muddy water, and at worst, you will come out the same. But if it works, you will be completely different, forever changed, and your dreams will be imagined. And I really think that's where we are as a people. We can sit here and decide to be, for lack of a better word, afraid of what's the worst that can happen to us, or we can move forward and pursue what can be the best that happens to us. Because here's the reality that doesn't often get talked about. People of color, Latino Americans, 3 times more likely to die from COVID. African Americans, 2.5 times more likely to die from COVID. This is of April 2021. This is not May 2020. These are the numbers still this year. We are still the population who's showing up in the ICUs. We are still the population who's ending up on the ventilator. We are not doing well in the midst of this crisis. And if we want to get our lives back, if we want to attend worship safely, if we want to go to work safely, these vaccines help us. These vaccines are our way out. And yes, I'm not telling you to fully embrace and trust the American medical system. That would be ludicrous. What I am telling you is to follow the numbers, take some comfort in the fact that African Americans and Latino Americans have been involved in this vaccine process from top to bottom. It was African Americans who took note of the disparities in the COVID. It was African Americans who came up with strategies for the vaccines. It's Latino Americans who started going out to the community. We have leverage in this. There's a higher level of accountability than what existed 50 years ago. So we have opportunities to not only get what we need, but we have opportunities to get what we need the right way. So as I sort of end my 15 minutes, I would say to you, if you're a clergy leader, encourage your people to get vaccinated. Maximize your Sunday morning sermon. Pretty much every sermon, the same way you proudly ask for tithes, proudly ask your people, have you been vaccinated? You yourself should be vaccinated at this point. If you have not been vaccinated, please get vaccinated. Share your own vaccination story. Find ways in the community where people can get vaccinated. If you don't have the ability to have a pod, find the closest pod and try to set up a whole vaccination effort. The same way we did the strolls to the polls that got Georgia's legislature upset. Let us also start strolling to the vaccine sites, because we want to make sure when the second wave hits that our people are not the people dying first, that our people are not becoming the long haulers. The long haulers means that even though you never spent a day in the hospital with COVID, you did get COVID and now you have heart failure. You did get COVID and now your lungs don't work right. You did get COVID and you end up having to have a toe amputation. Yes, you didn't end up in the ICU, but COVID forever changed your life. And we know that these vaccines, more than 500,000 people in around the world, these vaccines offer the protection needed. May God bless you, and please encourage your congregations and your community to get vaccinated. Get vaccinated, not ventilated. Thank you.
Thank you so much, Dr. Lydell. You know, in terms of what he said as well, I would like to say that we definitely have to move beyond fear. And so for those of us who have been involved in any of our work here at the center, you know that key to that we feel is education. Our slogan is learn, pray, act. And so this is sort of the foundation. Education becomes the foundation for any of the actions that we're seeking to take and encourage people. And so with that, I'm very, very happy to have next up on the program someone who really has devoted her life to that. You know, research can be very obscured for those on the outside looking in. So Dr. Amira Roaz, she's the professor of global and community health at George Mason University. But in reading some of her articles and some of her work really expands beyond the university. You know, whether it's low-income children and families in Fairfax County or Haiti and Egypt. So I'm, again, just in awe at just her commitment. And so she's going to take us into sort of what the research process is that her and her team has been, and I believe she's part of several teams working on some COVID research currently. But this is a way that we seek to build confidence in the process and building trust in the process. And so Dr. Amira, you are next.
Thank you, and thank you for the opportunity to come and speak with your stakeholders here, and for the opportunity to be on a panel with such amazing guests. I've been hoping to connect with you all at some point, so this is really a really great thing for me. So I have to say thank you. Well, what I would like to do is talk about my journey into research and how our teams have approached research in 2020 and 2021 as we're dealing with some really problematic social realities that have been magnified by the pandemic. So just for some background, I received a PhD in epidemiology, global health disease, epidemiology and control from Johns Hopkins. And then I moved into working on emerging infectious diseases and trying to understand what are the risk factors, what makes some populations more susceptible than others, and how do we truly identify populations that are most at risk? And then let's then take that information a step further and understand, what do we do about it? How can we reduce that risk? And then in order to do that, the reality is we need large teams from all kinds of backgrounds, all kinds of cultural backgrounds and disciplinary backgrounds. And we talk a lot about multidisciplinary work. So we need teams that are coming from different professional backgrounds who are respectful of each other and of each other's disciplines and can work well with each other and listen and hear what the other person is saying when they're describing the disparities that they're facing, the reasons for the disparities, and when they propose ideas for how do we address these disparities. And one of the biggest problems that we've had for decades in the US and in many other places is that we don't have that culture of being open-minded and really respectful when we're talking about disparities and when we're trying to come up with long-lasting, sustainable interventions and solutions. So after moving into the space of emerging infectious diseases and meeting, from the medical doctor to the veterinarian and the wildlife biologist to the marketing specialist and the communication health specialist, I then moved on to become an outbreak investigator at the CDC, where we worked on just what you all have been hearing about last year, contact tracing, figuring out how to identify populations that are undergoing or facing large outbreaks, and then what do we do about it? So I was at the CDC at that time and really got an inside look at how hard it is to work during an emergency, and you're doing everything that you can with 24 hours of the day, no more, and you're really trying to address sometimes disparities that are really outside of anyone's ability to close the gap on. And so, right, it just kind of highlights that we all need to work together and we need to have this open dialogue. So I moved on and found an amazing team. We worked on MERS coronavirus. That's the coronavirus that has affected the Middle East primarily. We did quite a bit of work to really get our team together. And one thing that I learned about coronaviruses really early on was that if we would have listened to the veterinarians more closely, we would have realized that they had been warning for 50, 60 years that coronaviruses are what the human health, the public health specialists need to pay attention to, because when they emerge and when they target a species, a population, they can have really devastating effects. And so that was one of the reasons why I became really interested in coronaviruses and ended up working on MERS coronavirus. So when COVID-19 hit, when this pandemic hit, we all looked at ourselves and we said, what can we do to help? How can we address the disparities in healthcare access, the disparities in health information, the disparities in who gets sick that we know are going to hit us? As soon as the pandemic hit, a lot of us were talking just about that. And what do we do in our own professions to make a contribution? So a number of us who work together on emerging infectious diseases and on other related public health issues, we started to come up with small outreach programs and research projects. And you sort of saw this happen throughout the world. We're all just trying to contribute and do our best here. So with our group, we had a team of nurse scientists, public health workers, and others, IT specialists, come together. And we said, let's really think through right now in April 2020, more than a year ago, who is being really hard hit and ignored. And there were two populations that our teams thought we needed to work with. One was the African-American pregnant women in the US. And The other population is the healthcare workers, the frontline healthcare workers, primarily those who are working on the nursing staff. So we came up with these two as being the populations that we felt we could work with the best, because these are the populations that we've been working with for a long time. And so, the process for research starts off with identifying the population that you want to work with, and hopefully it's a population that your team members have good experience with and they've built a relationship with over the years. And then the next thing is identifying that research question, that gap. And for COVID, we came together, and for the African-American moms, it was pregnant women, it was really, this is a population that over the decades, we know have poor access to healthcare. They have poorer outcomes for their pregnancies, for their newborns, than other populations in the US, and COVID-19 will certainly make that gap wider, right? And so the question for us became, how do we ensure that we can contribute information about the experience of African-American moms so that we don't just focus on the data that is easily accessible from wealthier populations. And we came up with a proposal, we submitted it, it eventually got funded, but it was a long time to get funded because it's just the way it is in the US. We were talking about disparities in April 2020, and it just took a while for the public media to pick up on it, and for a few months for calls for research proposals to start to say, we need to address the disparity. And I remember being on many calls where we were talking about disparities in Manassas, for example, and in other parts of Virginia and in Washington, DC. So our team, has been working really hard at coming up with the research questions, building up on our team's strengths and on the long-term relationship that we have with the community to come up with a research design that will ensure that we can effectively enroll participants and have an open dialogue so that we can answer questions. The data that we collect, the information that we generate, the whole purpose of it is to go back to the community and help the community in addressing the problems that we're all facing and that they're facing when it comes to COVID-19. So we are continuing to do a lot of work in this space and with these two populations. Some of our work has included early on surveys and sero surveys to understand who was infected and what were the risk factors for infection, and what could we have done and what should we be doing moving forward to cut down that risk of infection. My colleagues are working on guidelines to try to make sure that moms have access to the best information that they can, and that they have culturally appropriate messages that help them promote breastfeeding, for example. In the beginning of this, there was a lot of misinformation and a lot of fast guidance put out there that a lot of professionals were really concerned about. For example, if a mom is infected, separating her from the newborn, discouraging breastfeeding for the first few weeks. And once that information is out in the public domain and the science becomes updated and it says, actually, you can breastfeed, actually, it's better that you breastfeed, it just takes months to get that back to the community, and we really need to do better. The information that we generate from our research needs to lead to practice much quicker than what has been our standard of, believe it or not, it's been 17 years between the time a discovery is made and when practice changes. And, unfortunately, I think that 17 years is even longer when you're working with populations who are historically disenfranchised. And so when I look at community leaders, especially in the faith community, what I think we all need is a better connection and opportunities for community leaders to connect with researchers and to get some of their questions answered in real time. If you have members of your congregation that are vaccine hesitant, let's listen to them and hear why are they hesitant? What are their questions? And, it may mean that the community leader needs to take 5 days, a week or more to go to an expert, get questions answered, and then come back and share it with their community. And I think, that's happening in some regards, and we need to foster that with more partnerships. And I really encourage all of you who are in positions of leadership to reach out to your local academics, your local experts, your local health departments, and ask the questions. Most of the public health professionals that I work with are happy to take time to answer questions and to really try to dispel rumors and myths about vaccination and about other health issues outside of COVID. So I really encourage that connection. And I'm happy to answer questions about research and try to dispel any myths that I'm able to answer. Thank you.
Okay, so I'm over here like, I'm glad I was off camera. So she doesn't know. And I don't know everything that my guests are going to share. We help shape the program. But so she really hinted on something that really we're aiming to do as a statewide initiative here in Virginia, because we do see ourselves as that bridge between people of faith and congregations and the health care system and delivery. So, and particularly my world, since that's both of my hats merged together, it's really what I think about pretty much every day, most of the day during my work days. So I'll say some more about that towards the end, but thank you again so much, Dr. Amira, for highlighting that. And I definitely have some follow-up questions for her. So if you do, feel free, if you have questions from Dr. Lydell's remarks as well, drop them in the Q&A box and we'll answer them towards the end. And so right now, and I just really, there was one thing that, before I introduce our last speaker, here he is, Dr. Warren. I want to just emphasize something that Dr. Amira said at the very beginning. She talked about developing long-lasting and sustainable solutions. And that was a very powerful framework for me. And I do believe, and I hope I'm not overstepping, but when I first had my first conversation with Dr. Warren, that's what I felt. When he shared his vision of how he's shifting the paradigm of bioethics with a public health ethics and a research agenda, I just saw the sustainability in that. I saw just the power in that. And so, of course, with the historic work in Tuskegee around medical research, him leading the Bioethics Center there, as Dr. Amira mentioned, there's a plateau for vaccinations. And so people are having the conversations now as to what are the root causes to really examine, what can move us beyond this point. And earning trust is a central part of that. And I know that Dr. Warren has lots to share. So Dr. Warren.
Thank you so much. It's really an honor to be here and follow your leadership, Ms. Muhammad. And our two previous speakers have set the stage for what we need to do. I need to start off by saying without any hesitation that I believe in the whole public health paradigm of vaccinations. That's not the question. The question for me is not, do you get vaccinated? Don't you get vaccinated? That's an old question. Question is, the empowering question is under what conditions and under what circumstances? And that comes down to a very local, very community-based effort. So I want to get that clear so we don't start debating about should or should not. From my perspective, there's no question. Let me start my comments with a phrase, a proverb that drives all of my behavior. It is, I am because we are, therefore we are because I am. The African proverb simply says that we cannot be individuals singularly and have a society or a community. So we have to balance between the tension between what I individually need and what we collectively need. And that balance always will prove better for our community. Let me start again by saying there's hesitancy you hear, and I would frame my comments on pause. Pause, then move forward. Last year, we talked about pause because we didn't know enough. In 2021, we know enough to move forward, but we move forward with a pause, and that pause must be context within the framework of education. So a year ago, we did some work talking about the ethical problematic, published a paper entitled The African American Petri Dish. And it really talked about the historic health disparities experienced by African Americans, Latinx, Native Americans, some Asian American populations, and really that this issue of a new pandemic, a new virus, may be a bit new to some, but the issue of disparities is not new, it's old. So for anyone to say, to even imply that we did not know that if there was a pandemic, that people of color particularly would disproportionately suffer. And as the data now make clear, that was disproportionately African Americans, Latinx, Native American populations. And don't blame it on history. Blame it on both the combination of historical events and what currently is going on right now. Where you work, where you live, how you get to work, what you have to do is part and parcel of resolving this problem. So the paradigm is shifting, looking back to move forward. I don't believe that faith and fear can occupy the same space. And the beauty of this conversation is that we know people of faith and leaders in faith, faith leaders have an opportunity to speak truth to power, wherever the power may be. I mentioned that article that we published, but I also wanted to mention another one that talked about the relationship between the scientists, if you will, and the faith community. We did some work, did some interviews with top scientists around the country, particularly people of African descent, and top faith leaders. And we also went further to say the civic society. And when that conversation between those leaders, it was clear that there's a leadership role for both. We must partner, but it wasn't clear what that role should be. But leadership is clearly needed from both groups. And then we talked about leadership in terms of having a vision. And the vision is returning to a better place than we were before the pandemic and translating that vision into an action plan. And the work that's been done by the scientific community has been an action plan. And it's been wonderful to see it evolving. And now we know what to do. And the question is, do we have the courage and the gumption to do it? Whenever you talk about a problem, particularly as it relates to African Americans and other people of color, the U.S. Public Health Service syphilis study always comes up. They call it the Tuskegee syphilis study. And then some would say there's no connection between then and now. Others would say there's a direct connection between then and now. From my perspective, having worked around this issue for more than 20 years, I spent 20 plus years at the Centers for Disease Control. The issue is not a biological connection. The issue is a behavioral one. Do we trust the people to give us the advice that we need? And by people, I mean the science community. Do we trust those who gave us advice before to give us advice again? And so clearly, that example is what happened in the U.S. Public Health Service syphilis study at Tuskegee. No biological connection, but a behavioral one. Cultural insensitivity is what they lacked. They went to the church to get the men to participate in the study. They went to the Black church. So it was cultural insensitivity. They knew where our faith lied, and they went there and deceived us. Deception. Yes, they did. The federal government lied. The state government lied. And we wanted to soften that. They lied, they apologized, but apology is not enough. Everybody must be accountable. And last and most importantly, exploitation. And what's going on right now, in my view, is people are belaboring the hesitancy. And that's real, and we have to deal with that. People have legitimate reasons for being hesitant. But don't group all those who are hesitant in the same pot. It's a mixture of reasons why people are hesitant and why people will move forward. So don't connect the U.S. Public Health Service syphilis study to what's going on right now in a biological context. And they apologized. But what does the apology mean? You have to know better, acknowledge your errors, and do better. And what we must assure now is that we do better. Let me leave you with the kind of context that I think will help you to identify issues, raise the empowering issue so you can pause and then move forward. The issue for many is an ethical issue. You know, it's not, do we know the science? Do we have the science? But do we believe in the science? And I would argue that there's no doubt the science is good. And the important part about now is that the scientists are coming forth. We have trust over the years. Ethics is simply rules and principles and values and ideals of a particular group of people. The systematic study of morals, concepts, and theories, typically in departments of philosophy. So the group of people who need to take the message are the group of people who have the lived experience of the folks who need to get the message. The African-American faith community, the African-American health professionals, they've lived the experience, they can take the message to the people who need it. They are trustworthy sources, but they must be held accountable. Just because I'm Black doesn't mean I'm always accountable. Just because I'm a health professional doesn't mean I'm always accountable. Just because I'm a faith leader doesn't mean I'm always accountable. Everybody must be accountable. And then out of that ethics comes the notion of bioethics. That's the relationship and applied ethics focused on doctor-patient relationships and how the changes in the healthcare system affect it. The Affordable Care Act is a wonderful example how we knew what to do. We didn't do it for all of the wrong reasons. The states that were denying Medicaid expansion were those who were disproportionately where people of color lived and worked, Black and brown people. The relationship between what's needed and what was actually done, a big gap. That's what bioethics is. And as Ms. Muhammad said, the notion of public health ethics is where we find ourselves, because that's a relationship. It emphasizes the ethical problematic related to the interests and health of groups and the social justice of the distribution of social resources. The social justice and the distribution of social resources. Not hesitancy only, but for those who choose to be vaccinated, are we making it accessible? Are we making it acceptable? And that's the challenge. We don't need to put the coronavirus in the mix of health disparities. We have an opportunity to keep that from happening. We have an opportunity to not allow the coronavirus to become another health disparity disproportionately killing Black and brown people. Let's not let it become a health disparity. Let's strive toward this opportunity that the coronavirus pandemic has presented to us to reach health equity. That is, ideally, everyone should have a fair opportunity to attain their full health potential, and more pragmatically, that no one should be disadvantaged from achieving its full potential if it can be avoided. And I would argue that health disparities can and must be avoided. We can do better, and we will do better. Let me leave you with two quotes from two powerful people that I've read, studied, and admired over the years. And the first one is from Dr. David Satcher, the 16th U.S. Surgeon General, who also at one time was the president of Meharry Medical College, my alma mater, the president of Morehouse School of Medicine, and also the director of CDC. And Dr. Satcher said, we must know enough, care enough, do enough to make a change. And change gonna come, I would add. And last and most importantly, the wonderful, honorable Dr. Maya Angelou. And she said, and I leave you with this powerful quotation, history, despite its wretched pain, cannot be unlived, but if faced with courage, need not be lived again. We need not go through what we've been through to achieve where we need to go. And again, I close with the Sankofa bird that says, look back as we move forward. Bring our history forward as we direct our future. And thanks again. I look forward to exciting questions during this time period.
Thank you so much. Like I said, hopeful and inspiring. So I have a few questions. If you all have questions, I would want to say this sort of as a prelude, as a follow to what Dr. Amira had said that I sort of teased at the very beginning. This is our first sort of collective dialogue, but we are looking to hold more interactive drill down workshops following this for the rest of the year from now until December. Because there's a lot to unpack with what just my three guests today shared. So I'm so full. If you see my desk, I literally was taking notes when they were talking, and I have already 3 pages of questions. So I can't even get all my questions answered today. So I'm definitely looking, all 3 of them have committed to working with me. So I'm glad that I have not scared them away from the center and I work here. So I'm very, very excited. Dr. Lydell, I want to start with you. One of my follow-up questions for you was when we first talked, I was very, very moved by when your desire to focus on the Health Equity Project. And so as a clergy member, I really wanted, can you talk about sort of why that shift came about and sort of in your practice in New York, like why is that important? I think people focus on the healthcare system, you know, and all of the nuts and bolts of it. But I really wanted to see if you can zero in on the role of health equity in this conversation and why that's important.
Sure. This is a little bit different, although COVID to me, so a lot of people have asked at times the disparities of African Americans, Latinos in COVID. And I was doing something for a school in Minnesota, and I said to them, how many of you were surprised by this? And a lot of them were. And I said, that's the reality of the disconnect. You shouldn't have been surprised. Everything about our healthcare system suggests that African Americans, Latino Americans should have had the most problems with COVID. And that's where the equity linchpin of fulcrum matters so importantly to me, because we have all this technology, we have all this amazing science, we have all these resources, but yet still in every category that matters, African Americans are faring poorly. And we kind of know as a community that we have bad maternity, bad prenatal, but I don't think we really grasp as a community how really bad we are in every aspect of healthcare, even down to where I'm concerned that what we think is healthy living as people of color isn't healthy living. And so to see a pandemic or to see any kind of medical issue hit the country, I'm always expecting now people of color to have the biggest problems because we don't live well, and we kind of know nebulous wise in terms of the community, as the Reverend was saying, that we have these 2 different conversations going on. My 2 fellow panelists have made it clear. The researchers and the theorists, we all are talking, but the people on the streets have no idea what we're saying. And my mission is, how can I work with clergy leaders since they speak to the people in the streets way more often than the researchers do, how can I help them have a message that they feel comfortable with, that they feel their community will hear, that will make the theories and the concerns we have as researchers and public health officials more real for the people in the community. So when we talk about cancer, when we talk about diabetes, when we talk about obesity, and even when we talk about these vaccines, we're not being reactionary. Because that's part of the problem right now. Like we want people to have an experience they can trust, but we haven't established trustworthy pipelines. So with VAMBERT, that's my hope in 3 specific areas, being obesity, hereditary cancer screening, and universal healthcare, that working with churches from the small church to the denominational level to rethink how we do health ministry in the churches so that we really are a trusted pipeline of understanding for people of color.
Thank you. Again, I would done like 10 questions already just with that. Okay, so I just live in this space so much, and there's just so much work to be done. And so you touched on one of the follow-ups that I had for Dr. Amira, because I wanted to, if you can clarify, when you mentioned that it took a while for the radar and the conversation to shift on the disparities. at the beginning. Like you had the project, you all conceived of it in your research space, but getting the funding, like getting the support for it lagged. Wanting to sort of get a better understanding of that. And is there anything that health equity advocates, the community, sort of us as institution, what can help improve that lag time? Because disparity should have been, again, like we were saying, is not a surprise. And so wanted to sort of see what movement can we do in that space? And then I have one other thought.
That's a good question, and there's actually a little bit of data on it. So,
It's for Dr. Mira.
oh, I'm sorry.
Oh no, please! I want to hear.
I want to because it's specific to Virginia. Do you know what I'm saying? That's all. So, and then you can follow up, and then follow up. Yeah.
Well, I'll keep it short because I want to hear.
Yeah, I do too.
Yeah. Okay. Well, right. It was expected that we were going to see long-term disparities from COVID-19 because that's what we're constantly dealing with for every health issue, for every development issues, education, right? It's constant, right? And so it was really frustrating, but expected that we're going to write proposals and they won't get funded right away, and that it wouldn't be, for a few months before you saw specific calls for research that address health disparities. And the hope is that maybe now we can more seriously fund and support work that is meant to acknowledge and address disparities, right? And there's some fundamental issues with how we prioritize research and fund research as well. So we've always had this long lag between when a problem is identified and then when we actually come up with solutions for it. We've always had that lag. And I think part of it is the populations that are working on the ground most closely are the ones who often don't have an opportunity to be heard, to advocate for the populations that they work with. I think that's one of the biggest problems that we see.
And Dr. Lydell, I feel like I'm getting
So what I was going to say was that, as Dr. Warren alluded to, the notion of health and equity has been out since the research of Dr. Sachter in the early Bush administration, the Bush the father. And so we've known about this. And then there's the work of Daniel Dawes, and I can't even believe I'm blanking. I believe they've done a standing work of John Hopkins. So on an academic theoretical level, there's tons of data about health and equity in America, in the American context. The interesting thing is, though, America doesn't really move based upon research. America moves a bit based upon what people are fussing about. And what I was going to say that data is about, which Dr. Amir sort of talked about, we have this thing of seeing the money goes by the things that are advocated for. So just take it as this, and I'll say these three things: breast cancer, HIV, Alzheimer's. Studies were done that showed just how amazingly disproportionate the amount of money that is given in research dollars to breast cancer compared to the amount of Americans that are affected by breast cancer and the amount of Americans who die from breast cancer. Now, reading those papers remain conflicted because African-American women are doing horribly when it comes to breast cancer. But it's this thing of this disease is well known, from the Susan G. Komen Foundation to how it's every October, you got the NFL, you got the NCAA, everybody's wearing pink. Everybody knows that you must be concerned about this. Whereas you have pancreatic cancer, which probably didn't cross any of your minds when I said the other three, is the one that's really killing Americans in horrible fashions, but very little research has been given to it. I've seen in the past year, celebrities are starting to give some commercials to it with Patrick Swayze, who's now unfortunately gone from it. But that, unfortunately, is how we deal with public health, which goes back to the nexus of my organization, feeling if I get pastors who are community leaders on board and dialed in, that's how you move the needle. The money goes to the people who complain the best and are organized the best in terms of their complaining. It doesn't mean that their issue is actually a relevant issue. It just means that they're good at making their issue noticeable.
No, I appreciate that. If, you know, again, coming from a faith-based advocacy organization, I have homework to do. So thank you. That's part of our work. Do you know what I mean? Like really, yeah, how do we leverage our voices? So that is what we constantly churn about as staff. So Dr. Amira, one quick follow-up that you mentioned, which was the maternal mortality for Black women across the country is 2 to 3 times higher than our counterparts, and it's been one of my priorities here at the center. In fact, next week, I was able to get on the agenda for Virginia Board of Medicine's legislative committee meeting a request that implicit bias training and cultural sensitivity is mandated for all of their licensed practitioners. So hopefully, again, that will begin to shift. I was like, we don't need to do legislation. Can we just have the conversation about it? And so they agreed. So it's been something that I'm very, very passionate about. Interested to sort of see, since at the onset of the pandemic last year, and this was one of the recognized demographics that you were working on, sort of what has been the trend or the progression over the past year within that demographic that you've noticed?
Unfortunately, some of what we're seeing is that there is a large disparity in willingness to get the COVID vaccine. There is some fear and some rumors about fertility and development and mRNA vaccines. We're seeing that. We did a few surveys and we looked at which parents have the most vaccine hesitancy when it comes to themselves getting vaccine hesitancy. And we found 2 large groups, right? You have Black parents and you have, compared to their counterparts. And then you also have, when you control for all the other demographics, Republican parents. And it's for 2 very different reasons that they have this vaccine hesitancy, very different reasons, right? So unfortunately, you're sort of seeing this persistent hesitancy that is currently being addressed with very different messages because they're occurring for very different reasons. So that is something that our colleagues are seeing in their day-to-day interaction with a lot of the pregnant women. And then we did another analysis of healthcare workers to understand among healthcare workers, who are the healthcare workers that we're not able to convince to get vaccinated, right? And it's what we saw in the quantitative survey data is what we're seeing and what we've been seeing in real life in our clinic with our clinic partners. It's the same sort of thing that you're finding that the African-American healthcare workers have a higher vaccine hesitancy. And you're also finding that within all healthcare workers, it's the individuals who, are working more closely with the patients, right? So your role as a healthcare worker, your training is impacting your vaccine hesitancy. And then you also have the Republican healthcare workers, for very different reasons, have a very high vaccine hesitancy rate. It's a long answer to your questions.
No, it's good. Again, so if you know how my mind thinks, when you think, I was like, okay, need a research to dispel myths on fertility and mRNA. Like, I'm constantly thinking of what to do. So no, that was perfect. Thank you for that. And then the last question I have for you is, Dr. Warren, as we round it up with, I'm again thankful that you are, with all of the sort of the depth of the darkness that you go into in this work. As Black people, we've suffered so much in this country, and that you are so hopeful. And so I really want you to talk about the evolution of trust. I don't know if you recall that. And so that is the note that I want to end on. I will make you, I feel like I think it's Lawrence O'Down who does, and you will get the last word. But before I do that, so one of the things that as a follow-up to this recording will be released with 2 new resources. One is a congregational guide of what to do, what people, members of congregations can practically do to support Virginia's vaccination rollout and plan. So a host of things, some Dr. Liddell touched on that he would wish to do, some pastors who've already done it. And so I've already basically collated everything and put it together in a very practical guide. The other resource is actually a toolkit for clergy leaders, again, with what Reverend Dr. Liddell talked about. Again, being clergy kind of has a natural sense of this, but really, so it has like sermon topics, scriptures, and so this is, and it's truly interfaith. So it's from all of the 6 major religions that we engage with here at the center. And so those 2 key resources are coming out. And then for the individual, we've crafted a survey, because what we want to do over the course of this series of workshops that will follow this symposium from now through December is really begin to gauge how sentiment and perspectives changed as people get more information, better information, understand information better. So those kind of 3 layers. So there's actually a link, tinyurl.com/VICPP bioethics. And so that will be standing, and we are going to do specific surveys for congregations that are engaged in our survey assessment, to specifically sort of see how trends change within their congregation as they begin to get more information, to sort of see as we build these relationships between, as Dr. Liddell said, a trustworthy pipeline. I love that. I absolutely love everything we shared today. And so with that, I want to thank our guest again. I want to thank our attendees. And for those of you who are watching this as a recording, all of our resources that I mentioned leading up to this as part of our initiative can be found on our health equity webpage on our website, including the link to the survey. So if you watch this as a recording, please take the survey. We want to basically engage and understand what are some of the questions that people are having, like Dr. Murray mentioned, so that we can really begin to develop and address them. And so with that, Dr. Warren, I do want to close out with your comments on the evolution of trust, which for me is foundational in everything that we're doing. Thank you all.
Okay, let me say this without apology. Stop asking us to trust you. Prove yourself trustworthy. Different paradigm. To prove yourself trustworthy, it means you've got to spend the time with community, and you've got to repeatedly demonstrate that you're open and out. Stop looking and trying to fix the disease. Try to help the people be healthy. Different paradigm. Don't look for the disease. Look what makes us healthy. Ask us and we know. So I think the notion of trust must shift to trustworthiness. It shifts the paradigm, and it's for the research community, for the practitioner, you have to do better and have to expect us to do better. That's fundamental. Let me leave you with I think, a really important for me framework. Promote, protect, and prevent in the midst of the coronavirus pandemic. What do I mean by promote? With the coronavirus pandemic continuing and vaccinations being available and more available, the country is still enraged. Let's focus on what do we do to promote our health? Eat the right foods. Take care of your body. Get along with others. Respect and protect the environment. And believe in a divine order to the universe. That's the promotion beyond the pandemic. What about protect? Protect yourself and community. If you don't get vaccinated for yourself, get vaccinated for community. You know, you can't, don't be so selfish that to say it's only about me. It's about us. So do it for us. And I think if you do it for us, collectively, we will be better. And we're not trying to convince you to do the right thing. I'm trying to provide the information for you to make the informed decision to do the right thing. And last and most importantly, prevent community spread. You see, because you're okay does not make it okay. Where you go, what you do, who you interact with is critically important. So wear your mask until you're sure that it's okay not to wear the mask, because that's the principle that just came out. It doesn't apply to everybody. I'm at Tuskegee, and the president says we're going to wear our masks throughout the semester and throughout the summer, because it sends a message that we care about you as well as ourselves. And last and most importantly, I think the conversation that's going on now must continue. We don't have to agree. We can agree to disagree, but we all must agree that the health of our people is in the best interest of all of our people. And let's shift from quote unquote health equity to what John Chazelle, an African-American physician, my mentor, says, let's talk about optimal health. Help you and us to reach our greatest state of aliveness. Your greatest state of aliveness, not just not being sick, but your greatest state of aliveness is where we all must go. And I think the faith community has leadership, will continue to have it, and I'm so proud to be among them.
Thank you so very much. And yes, the conversation will definitely continue, and I hope you all will continue to be with us for those conversations. Thank you all. Have a wonderful afternoon.